Okay, let's dig into this. We're focusing today on something very specific, but, well, incredibly important. Amaurosis fugax.
Right. That sudden temporary blindness in just one eye, it can be really frightening for patients.
Exactly. And it's so crucial because even though it passes, it's often a major warning sign. Could be for a stroke or even permanent vision loss down the line.
hmm A real red flag.
So our source material is the Amaurosis Fugax Management Protocol from 2025, and our mission really is to pull out the core pathway it recommends, how experts are advised to diagnose and manage this quickly to reduce those serious risks.
And it's a very structured protocol, which is vital when time is of the essence.
Absolutely. So where does it start? The protocol lays out a clear first step, right?
It starts immediately with the ophthalmologist making that accurate clinical diagnosis. It
Yeah.
usually means, a good fundoscopic exam, documenting that it is transient monocular visual loss.
Okay. Diagnosis confirmed. Then what? The urgency kicks in.
Right away. The protocol spells out an immediate, same-day diagnostic workup. No delay.
Same day. Okay. And what does that essential workup? What does it include?
It's designed to quickly catch the big, high-risk causes. So you get a vascular check with an urgent carotid duplex Doppler ultrasound that looks at the internal carotid arteries for any narrowing stenosis.
Okay, carotid arteries checked. What else?
A mandatory 12-lead electrocardiogram, an ECG. That's screening for things like atrial fibrillation or other heart issues that might be throwing off clots.
Makes sense. Heart sources.
Another,
And there's something specific for older patients.
yes, critically. For anyone over 50, it mandates blood tests, the erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. That's the screen for giant cell arteritis.
Ah, GCA, which needs very rapid treatment to prevent blindness.
Exactly. It's treatable, but you have to find it fast.
Yeah.
So those three, carotid ultrasound, ECG, and the GCA bloods for the over 50s, that's the initial urgent screen.
So it's really a hunt for the most immediate dangers. Does the protocol talk about risk scoring early on?
It does, yeah.
Yeah.
It explicitly recommends using a validated risk score, like the ABCD2 score.
Okay, ABCD2. That looks at age, blood pressure, clinical features.
Duration of symptoms, and diabetes, exactly. It helps put a number on the immediate stroke risk and sort of guides how aggressively you need to move forward.
Got it. What about brain scans? Is everyone getting a computer tomography or magnetic resonance imaging scan?
No, not automatically. The protocol says brain imaging is for selected patients. Like if someone comes in with other neurological symptoms at the same time, maybe some weakness or speech difficulty.
Okay. Or if the presentation is unusual.
Right. Or if the eye exam itself shows signs of a retinal infarct, suggesting something more central might be going on. It focuses the imaging where it's most likely to yield answers.
That seems practical, targeting resources. So after these initial tests, particularly the carotid ultrasound, the management path seems to split.
It really does. The findings from that ipsilateral carotid duplex, the one on the same side as the affected eye, are key.
Mm.
If the stenosis is severe, say 70% or more.
High-grade stenosis.
Yep. Then the patient is generally considered a candidate for surgery, a carotid endarterectomy, to clear out the blockage. Plus, they immediately start optimal medical therapy.
Okay. Surgery plus meds for severe stenosis. What about moderate stenosis, like 50 to 69%?
Also considered for carotid endarterectomy, but it's a more nuanced decision there. You weigh the risks and benefits for that individual patient, their age, other health issues. But again, optimal medical therapy starts right away.
And if the stenosis is less than 50%, mild or none?
Then the main strategy is optimal medical therapy alone. But, and this is important, the protocol emphasizes you still need to aggressively look for other causes if you haven't found one, especially those cardioembolic sources or GCA, if that wasn't ruled out.
Right. Don't stop looking just because the carotids are clear. Let's talk about optimal medical therapy, or OMT. The protocol gets specific there, doesn't it?
Very specific. It applies to basically everyone unless there's a contraindication. There's a particular approach to antiplatelet therapy that's highlighted. Starting dual antiplatelet therapy, usually aspirin and clopidogrel, but for a defined, fairly short period. It specifies 21 to 90 days.
Okay, short-term dual therapy. Then what?
Then transition to long-term single antiplatelet agent monotherapy. And for cholesterol, there's an update recommending high-intensity statins.
High intensity, like atorvastatin or rosuvastatin at higher doses.
Exactly. It gives examples like atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams. The goal is a significant drop in LDL cholesterol.
And it's not just pills, right? Lifestyle's in there too.
Absolutely. Optimal blood pressure control, quitting smoking, diet, exercise, managing diabetes, those are all core parts of OMT. It's comprehensive.
So a robust medical plan for all patients, tailored by the findings. The protocol also seems big on teamwork.
Hugely important. Multidisciplinary collaboration. It recommends consulting neurology if there are any atypical features, diagnostic doubts, or those concurrent neurosymptoms we mentioned.
In cardiology.
Cardiology consult. If the ECG is abnormal, if you suspect an arrhythmia, or, crucially, if you don't find significant carotid disease, suggesting the heart might be the source.
And it even names a coordinator.
Yes, it explicitly names Dr. Gregory Weir as the point person for coordinating these special investigations and specialist consults within this specific framework. Having that single contact point is vital for speed.
Seems like it would streamline things immensely. How about follow-up?
Patients managed just with OMT get a repeat carotid duplex scan at 6 months, or sooner if symptoms come back. Surgical patients have standard post-op checks. And crucially, there's feedback to the referring ophthalmologist.
Communication is key.
Definitely. Telephonic feedback and arranging a follow-up appointment for the patient back with their ophthalmologist after discharge.
And finally, the nuts and bolts, the logistics.
Yep, it covers that too. Contact info for Dr. Weir. It specifies urgent scans happen at Life Eugene Moraes Hospital for that same-day service. It even mentions offering admission for patients with transport issues or needing a bigger inpatient workup, like Holter monitoring.
Practical considerations. And data.
Yes, all patients go into a prospective database. Anonymized data gets shared regularly with the Pretoria Eye Institute for review, learning, improving the process.
So let's pull this all together. What this protocol really describes is this incredibly clear, rapid pathway. It starts right from the ophthalmologist's diagnosis,
Moves through urgent, targeted tests for the big vascular, cardiac, and inflammatory risks.
uses things like the ABCD2 score for risk assessment, decides management based heavily on carotid stenosis,
Mandates that optimal medical therapy for everyone, with specific details on things like dual antiplatelets and high-intensity statins.
builds in the multidisciplinary team, names a coordinator, sorts out the logistics like where tests happen, and even manages the data.
It's a really comprehensive framework for handling a high-stakes situation with structure and urgency. Shows how evidence-based guidelines can work in practice.
Absolutely. So thinking about this, this highly structured, evidence-based approach, it really highlights the power of having a clear plan for critical situations.
Definitely. It minimizes variation, ensures key steps aren't missed, and aims for the best possible outcome when time is critical.
Which makes you think, where else, perhaps in your own clinical work, or even more broadly, could applying a similar structured, coordinated, evidence-based approach help manage complexity and, well, reduce risk? Something to consider.